and you are sort of stuck here, scratching your head. And so this is kind of a black box to you. And so I just want to make it a little less of a black box to you. So the first thing is to sort of break down types of dialysis. And so I tend to break this down into dialysis in the community, right? So we have our in-center 3 times a week conventional hemodialysis. You may not know this, but it's not often used. There is a form of in-center 3 times a week nocturnal dialysis where people dialyze at night for a little longer than 4 hours at a time, but still about 3 hours a week. Then we have home-based therapy. And so there is home hemodialysis, which is typically called slow daily dialysis. It's basically conventional dialysis, not slow daily, short daily, in very short intervals that occur every day. And then, of course, peritoneal dialysis. In the hospital, you're going to get your conventional intermittent hemodialysis. And then you're going to get these, quote, continuous dialysis therapies. And aside from peritoneal dialysis, which we can do in hospitals, we can't do that at the VA currently, but we can do that in DH and university. This is going to be your SLED and your SCUF and your CVVH, your CVVHD, and you're going to hear stuff like PIRRT and all these terms you don't really understand, but we'll go through those a little bit. So let's go back to our guy. He's got a serum K, said 7. And the first thing that catches our eye is kind of that, and he's uremic and all this stuff. And so if you want to clear small things and clear them quick, the way to go is hemo. And before we go through exactly how it works, a real quick primer on access. All right, so you guys are used to these things. These are our dialysis catheters. And the way they work, we usually use Maherkers. So this is the right atrium. This is the SVC. We like these things with the tip at the cavo-atrial junction. That's where we get the best dialysis. And basically, blood is flowing to the right atrium this way. So we like to take blood from this port. That goes to the dialysis machine and back from the dialysis machine back to the patient. So these come in different shapes and sizes. And so in length, we like the right IJ to be about 15 centimeter line. And then the left IJ or FEM, we tend to run 20 plus centimeter lines. In terms of the diameter, these things range from 10 to 15 French. With the 15, the big guys, those are your tunneled dialysis catheters. And we like short, fat lines with only 2 lumens. And that is going to run in a little bit of, you guys like this little VIP port thing that comes out in the ICU. So you can run vasopressors or whatever else. It limits the diameter of the lines. So we sort of fight about that sometimes, but we understand, when you need it. But these are the kind of, and so we like them here. And we like the bigger lines, and that gives us the best dialysis. Circuit stays open longer, less clotting and less blood loss, and better clearance. As far as how we do dialysis on a long-term basis, so you've heard about fistulas, you've seen fistulas. From the 50,000 foot view, terms of nephrology speak about what fistulas are, we have an artery, blood is flowing through. We have a vein. The artery flows back up the vein through this thing right here, which is the anastomosis, which is our vascular surgeons who do this are very talented. And so the artery we call the inflow, the vein we call the outflow. And it's actually the outflow, or the outflow tract, because this goes all the way up your arm, through your subclavian, innominate, SVC, depending on where you are. This is the thing that our dialysis nurses stick with hollow needles. All right, so we got blood flowing this way. We want the proximal one to go to dialysis, and we want the distal one to go from dialysis. Now, and that's just kind of fistulas in a nutshell. These things obviously get much more complicated. Fistulas work from radiocephalic, and they're usually, the way we speak about fistulas, if it's a radiocephalic fistula, it's always artery, vein. So it could be brachial artery to basilic, or brachiocephalic. That's kind of all the convention. These things, grafts, you can have grafts that connect an artery to a vein. There's lots of variations here, and I don't really want to go into that. But basically, the way, stepping back from access, when this, to go over a quick primer on the circuit, when this goes to dialysis, this limb, which we actually call, confusingly, the arterial limb, because from the perspective of the dialysis machine, it's going to the dialysis machine, goes to a pump. And then it comes to our filters. And it goes to another pump. And it goes back. Again, sorry about my terrible cartoons. I know they're bad. I'm trying my best. So blood comes this way through the dialysis filter. Separately from that, we've got these big containers on the bottom of the dialysis machine. That's our dialysate. And they're combined. Keep them separate because some of the constituents will solidify if we don't keep them separate, but we mix them right before use. And the dialysate runs countercurrent to the blood flow. And when it leaves the filter, this is what we call effluent. And that goes in the trash. And that's basically dialysis in a nutshell. Blood to the filter, countercurrently dialysate bathes the other side. And so if we go back to potassium, let's do a two-dimensional view of this filter. Let's say blood is going into the dialysis filter. It's going away. So we've got a blood flow. We'll call that QB. And then we've got our dialysis flow, our dialysate, our effluent. Call this QD. And if we think about the way dialysis works with respect to serum K being high, remember that guy had a serum K 7. Dialysis moves things by the principle of diffusion. So the way I do this is I build a dialysate K that's lower. Now I've got a concentration gradient from high to low, and this will move here, and the excess potassium will go out with the effluent, and basically the serum K will go down. Make it 5, going back to the patient. So diffusion is good. Things move from high concentration to low concentration. And so diffusion is really good for stuff that has concentration gradients, high concentration gradients. And I'll say that's actually high. The level can be high in the blood or low in the blood. And things that are small. So all this stuff ends up being potassium and your other divalent cations like mag, calcium, urea moves pretty well. protons move, bicarbonate moves. So when I say, high and low, or high concentration gradients, like K is high to low. Calcium often in dialysis patients is low. And so we set a calcium bath higher than their serum calcium. So that's hot, that's low to high. So stuff can move this way. And that's diffusion. So good for stuff that has high concentration gradients, good stuff that's small. What is it not good for? It's not good for big stuff. So I'm going to say like phosphorus, creatinine, and and then stuff like troponin, myoglobin, all that kind of stuff. So this is how you deal with small molecules and deal with them quickly. And this is very fast and very efficient as long as things have concentration gradients. So when I write the prescription here, I'm setting a blood flow, or when the fellow does, let's say he sets a dialysate flow and he builds his dialysis bath. And then you can do this over a period of time. Any questions about dialysis? I know it's pretty simple stuff. It's about to get a little more complicated. Okay. All right. Make sure you guys still there. So quiet. Okay. All right. So we said the guy had high potassium and all this stuff. So we did dialysis, but that doesn't solve this problem. And the 92% on 4 liters. So if we remember our body compartments, we've got our ICF and our ECF. And for reference, total body water distributes across both spaces. Total body potassium is only in the intracellular space. And total body sodium in the extracellular space. And when you looking at these people with hypertension, hypoxia, edema, pulmonary edema, ascites, you're making a physical assessment of the extracellular fluid space being expanded. Now, that's a problem. You might say, why can't we just dialyze that off? And so the problem there is, let's say if your plasma sodium is 140, well, if this is just sodium, maybe I could build a dialysate with concentration of 100. And then through my dialysis principle I just talked to you about, stuff would move, total body sodium would go down. But the problem is the serum osmolality is largely determined from sodium. So I will start with a really high serum osmolality, and I got a lower dialysate one, and then I will rapidly drop my osmolality. Oh, and by the way, because that happens, water is actually going to go back into the patient by osmosis because you're dropping your osmolality, or you have such a great high gradient here. So that's going to end up crashing your blood pressure. And when you start lowering serum sodium, what happens? Like, what are the complications of acute hyponatremia, cerebral edema? That's bad. So if we did this is the way we got salt out of the body. It'd be a hell of a problem. So we are going to remove salt from the body and water by ultrafiltration. That's the second big principle of dialysis. So ultrafiltration is different than dialysis. We have no dialysate. We have actually the same membrane. We have blood coming in as before. But instead of a dialysate, so no dialysate, we are going to apply a pressure here. These little points, transmembrane pressure, and we're going to force fluid out in bulk through a principle called convection. And so let's go back to K for a second. If serum K was 7, there's no dialysate. So if serum K is 7 over here in the blood, in your effluent, which is what's going to come out, your effluent K is going to be 7. And, well, why couldn't you get rid of K that way? Well, a typical dialysis treatment, if you think about it, is, let's say 4 hours, and let's say you get like 4 liters off somebody. So 4 hours, 4 liters, and let's say you remove 7 milliequivalents per liter of K. So 7 times 4 is 28. So does 28 milliequivalents sound like a lot of K? It's not. That's like a lettuce leaf. And so that's not a great way to get something like K out. But if you think about what your sodium is 140, your chloride is 100, and your total body sodium is in the extracellular space. So what's 140 times 4 liters? That's like 560. So that's like 10,000 milligrams of sodium. It's a lot. That's how we get rid of salt. And so you're going to get rid of total body salt, total body chloride, and total body water. And the principle, again, that you used was this convection. And I applied a pressure here, and I just forced fluid out. So if my sodium's 140, my K is 7, my bicarb's 20, my BUN is 100, my creatinine's 10, it's exactly what it's going to look like on the other side. You just force it out in bulk. So you can get rid of a lot of sodium, a lot of chloride, and you do get rid of some urea, although not as much with dialysis because the way that urea equilibrates across body surfaces. So if this looks familiar, it should, to give you some, going back to med school. So this is modeled after what happens in the kidney, right? So we got our glomerulus, our afferent arteriole, and our efferent arteriole, right? And this is our proximal tubule. And so what happens is we apply pressure here at the efferent arteriole, a little more than the afferent arteriole, and we create an ultrafiltrate of plasma. So we got our red blood cells and our proteins and stuff. But then we have like plasma water plus electrolytes. That's if you sampled the urine right after the glomerulus, that's what you find. And so the concentration of sodium, chloride, potassium, everything is the same before the glomerulus as after. And it's only after it reaches your tubules that your tubules start screwing with it and reabsorbing and secreting electrolytes. And so the principle of UF, you could think of it as a form of like glomerular ultrafiltration and convective clearance, like waves in an ocean. Concentration of any substance X here, stuff is moving this way, it's going to be the same here. So when you put those two together, in a hemodialysis treatment, it's basically diffusion plus convection. So you get hemodialysis and UF, and that membrane we talked about can do the same, does it at once. So blood goes in, dialysate goes in, you get dialysis, we apply pressure, you get ultrafiltration, you get it all at once. So your patient goes from being hyperkalemic and volume overloaded to feeling fantastic. Well, maybe not feeling totally fantastic, but feeling a hell of a lot better. And that's conventional hemodialysis. The access, the circuit, all that makes sense from a 50,000 foot view. Any quick questions about conventional hemo? Okay. All right, real quick, before we get to CRRT, I know that's the one that causes kind of the most confusion. I do want to talk a little bit about peritoneal dialysis. You guys don't get a lot of this. You see, the reason you don't get a lot of this is that most of these patients do really well. And so you only see sort of the disasters that come in, and that's few and far between. So peritoneal dialysis is what I would do and what any sane person would do if they could, waiting on a transplant if you're eligible. And so this is a two-dimensional view of the abdominal wall. Again, don't laugh at my cartoon, sorry. So we'll make this the guts here. intestines and everything. This is the peritoneal membrane, and it places 1 cell thick. And then this is the abdominal wall. Let's give it a little bit of subcutaneous tissue. And then this space in between is the peritoneal space. So the way PD works is we have a catheter, gets buried and tunneled in the subcutaneous tissue, and then it goes into the peritoneum, coils up a bunch, and it settles in the pelvis. And like that hemodialysis line, if you remember, it's got some fenestrations, only the PD catheters have a lot of them. And this goes to the most common form of PD, which is something called APD, or automated peritoneal dialysis. This goes to a cycler. It's got another pump, and it's got like these bags of dialysis attached to it, of dialysate. And the steps for PD, one is that the dialysate goes in. So it goes in here, goes in this catheter, goes out through these little fenestrations. And unlike traditional dialysate, it's built, the dialysate is the exact same. The only difference is it's not isosmolar to plasma, it's hypertonic. And so, and that's how it works to get stuff out of the peritoneal membrane. So it has a high osmolality, and it's dextrose. So it's got a lot of sugar in it. And the high osmolality is going to draw stuff by ultrafiltration into the peritoneal membrane. So there's your UF. And because it's built like a dialysate, you're going to get stuff that moves back and forth according to its concentration gradient. So you're going to get basically ultrafiltration and dialysis. It's got to happen over a period of time. So the second step is called a dwell. And so this dialysate sits there, you let it equilibrate for a little period of time, but you can't go too long, because if you go too long, everything just equilibrates on both sides, and then the efficacy goes down. So step 3 is dialysate is taken out by the machine, and it goes out the same way it came in the same one catheter, and then the effluent is discarded. And you repeat this throughout the night until, in the end, the dialysate goes out, and you may do something called a day dwell. And so a typical dialysis PD prescription, you do like a time. So let's say it's going to be 8 hours at night. You pick the volume. So you say, I want 2 liter exchanges. You pick a number of exchanges. Say we do 4 exchanges. So that gives you a total volume of 4 times 2 is 8 liters. And so 2 liters goes in, and each dwell, is 4 exchanges over 8 hours. So each dwell is 2 hours. And then at the very end, you go dry, and then you may or may not get a final solution of something called a day dwell, which is the exact compositions of these dialysates are probably not matter to you too much. The day dwell is a little different. It's got a longer acting form of dextrose called icodextrin that doesn't get reabsorbed by your peritoneum, so it can kind of give you UF and HD throughout the day at a minimal level. But if you look at it from a day-night perspective, a patient on PD, this is nighttime, this is daytime, does PD at night, and then they may go quote unquote dry during the day. We do that sometimes for people, particularly if they're early starts to PD, they don't need a day dwell, but then they just do a little bit of dialysis. So this is kind of a 24-hour, but mostly intensive at night. So this is called APD, or automated peritoneal dialysis. There's another form. This is what happens most of the time. You're going to hear CAPD, and this is continuous ambulatory peritoneal dialysis. And the only difference here is that this is no cycler, so you're doing this manually. So what that means is you basically take these bags, you do this throughout the day, and you hold them to gravity and you fill your peritoneum. You tie off the bag, you go about your day. 2 hours later, you drain, you reinfuse, you drain. Why the hell would you ever do this? Well, this is what they do before the cyclers came about. And this, we train people to do this actually before they do the cyclers, in case like there's an electricity, a power outage, you're on a trip, your cycler's misplaced. This is kind of like disaster mode. You need to know how to be able to do this on your own. So why would you do PD? Well, so the advantages of PD over, let's say, conventional in-center dialysis. The first advantage is that it's yours. Right? So this is something you're doing for yourself versus when you go to a dialysis center, somebody else is doing it for you. And so there's a lot of control here. So that's good. Of course, it's done in your home. So that gives you more freedom. You're not tied to a chair 3 times a week, right? You probably, so quality of life is better. Blood pressure is probably better. It's lower. Your electrolytes are better, and so your diet is more liberal. Because this is done, it's less efficient on a minute-to-minute basis than conventional hemodialysis, but because it's done for so long, you get better control of your electrolytes. You can actually liberalize your diet. As far as mortality, we don't have hard data. You'd think that'd be interesting in 2021. It's been around forever. But you can imagine creating a randomized trial of patients, PD versus HD. That's really hard to do. People have their preferences. The data would suggest that it's probably more favorable. It's certainly more favorable at preserving the residual renal function you have. So your native kidney function doesn't drop as fast. There's less hypotension. There's less little like mini AKI hits you get on top of CKD that hemo can give you. But there are some downsides to this, right? So some disadvantages. Well, one, it's the same. It's yours. And that can be a problem. You can burn out. So there's a lot of burnout on PD because this is like a full-time job. And so a lot of people, even who do this well, need breaks, and they need to go to hemo to give them a respite before they go back to PD. PD fails. So unlike HD, which you can continue for decades if you want, the average lifespan for a good peritoneum is about 5 years. So what happens is, we toss hemodialysis membranes, the filters away, but you can't toss your peritoneum away. And so you get peritoneal sclerosis, and the efficacy of this sort of wanes over time. Some people can last 7-10 years. I've seen that before. They're rare. But in general, the efficacy goes away over time. And if you're on this long term, you need to go to hemo. A lot of patient factors impact that. And of course, you admit guys with peritonitis. That's the great fear, peritonitis. The thing I'll say about PD patients is that 3/4 don't get any. You guys see the 1/4 of patients who do. And what I mean by that is these 3/4 of patients, and statistics show this, never get peritonitis, or if they do, they get like 1 episode. So it's these guys, there's people that get repeated peritonitis that end up in the hospital. We treat them as outpatients, so a lot of times you don't see them. We just give them intraperitoneal antibiotics. If it gets real bad, we got to give them systemic antibiotics. But there's just certain patients that get PD, and sometimes it's the stuff you anticipate, like they're bad diabetics, and they have poor sterile technique. But sometimes people do great, and their blood sugar's fine, and their sterile technique is fine. They just get peritonitis, and they just get recurrent, and it's a real problem. And it's hard to predict. And probably, let me see, so burnout, failure, peritonitis. And the last thing I'll mention is that there is a bias, a selection bias here. for obvious reason. So not everybody can do PD. Like, so if you're old and you have no caregiver and your eyesight is poor and your coordination is poor, you can't do PD. It's a disaster. So a lot of the patients we have to pick carefully. It's a little unfair, but it is what it is. So younger, healthier people, but even we have very sick people that do PD. For instance, it's kind of interesting that the people on PD tend to be like really quite healthy younger people waiting on transplant, or really sick old people that can't tolerate chemo because of their hemodynamics. But the one thing that's common among all of them is they have great support systems, great caregiver support, because if you don't have that, you're not going to survive PD. Any questions about PD? I'm on this whiteboard. I'm trying to see. I know there's a chat here. Let me pull up the chat. Is PD contraindicated if someone has ascites? No. Great question. We do PD on people with cirrhosis and ascites. I know it sounds kind of nuts. Your protein losses might be a little higher, but Isaac Teitelbaum is our PD expert at the U, and he's done this several times. And there's published data that people with liver disease and ascites, you can do PD on. You can even do PD in pregnant patients. I know that sounds nuts. We generally switch them to hemo towards the daily hemodialysis towards the end of pregnancy. There's been a couple that actually taken them all the way through the postpartum period of PD. That's rare, though. I know it sounds crazy, but you can do it. So it's generally well tolerated. It's what I would do if I was waiting on a kidney transplant. But like I say, it has some drawbacks. Okay, just close some of these off. I don't know how to get rid of these. Ugh. Create up to 10 whiteboards. Again, I'm just trying to figure this out. Sorry. Bear with me. Okay. All right, finally, CRRT. Now this drives you nuts because it drives me nuts. So forms of CRRT generally fall into what we call slow, prolonged, and continuous. And the forms of slow, prolonged is going to be a little complicated, but here's kind of how we can think about it. So we've got slow, low efficiency dialysis called SLED, slow continuous ultrafiltration, and that's kind of and then we've got something called PIRRT. We'll go into this. And then we have quote unquote continuous, and we've got something called CVVH, which is actually, every time you hear that, it's actually CVVHF. And we'll go into hemofiltration in a second. CVVHD. Now I've created these categories because I'm actually going to put scuff here, and this is going to make sense in a minute. So you are training at a program that actually splits this nicely between institutions. And I put these boxes around the machines that can do this. So at the VA, what we do is SLED scuff. And what we use to create SLED scuff is just our conventional HD machine. We call it the big machine, the big machine. This is what we do intermittent hemo with. Now at UH and DH, we have these ICU machines, and they're different. Now, the difference here is that this is run by an HD nurse. This is run by an ICU nurse. So there's trade-offs here, right? So the good thing about using this ICU machine is that you don't tie up a dialysis nurse. So that's good because our dialysis nurses are in short supply. This you can really run 24/7. And there maybe is some data not really versus SLED scuff, but there's some favorable data in like burn patients and cardiothoracic patients that this may be the way to go. You get better volume control. But to tell you the truth, the published data comparing one machine versus the other, there's not much difference in terms of outcomes. So everything you can do with these little ICU machines, you can do with the big machines. You just need to change the time you do it. There's trade-offs here too. So the ICU's nurse is tied up one-to-one. They don't like being tied up one-to-one. And so as soon as you can get the patient off CRT, they like, to move back here to more conventional stuff and running, intermittent HD. And another thing is that these little machines and the supplies are expensive, way more expensive than using the conventional machine and doing this sort of sled scuff thing. So the VA, as a institution, has decided not to invest, and this is across VAs across the country, in these little machines because they're not really hard data that they're better than sled scuff. And so sled scuff is basically, the way it works, it's hemo. Sled refers to kind of that diffusion part, and scuffed, the ultrafiltration part. And in an unstable ICU patient, we tend to split it. And so a typical RX is like 6 hours of sled, let's say 6 hours, alternating with 6 hours of scuff. And the numbers don't matter, but our blood flow is lower than it is in conventional. Our dialysate flows are lower, and our bads are a little different. So for instance, instead of like 2K bads, we do like 4K bads or 3K bads, because even though this is slow and it claims to be low efficiency, when you do this over a long period of time, it's actually more efficient than a 4-hour treatment. So you can get really like hypokalemic. So the bads tend to be a little bit different. And then with UF, the UF portion of this, you may take off volume during the sled treatment, but often these patients are hemodynamically unstable. And so you're going to do UF separate from HD, and you just set a UF goal. And you say, I want 4 liters off in 6 hours, or you can say I want 100 mLs off per hour net. And we'll go to this net thing in a minute. And with CRT, whether it's CVVH or CVVHD, we'll go into the difference here in a second. You're setting this a 24-hour prescription. Again, the blood flow is lower, the dialysate flow is low, or the therapy fluid is low, and the bath is different. And then you set a similar kind of thing. It tends to be like, I want 100 ml per hour net off. The way the net thing works is, let's say we got hour number 1, hour number 2, hour number 3. Let's say the patient had no fluid in and they're anuric. They have nothing out. And if you set a goal in the ICU of negative 200 mLs per hour, what the ICU nurse is going to do is basically change the ultrafiltration rate and take off 200 mLs here. And let's say hour 2 goes by, though. In hour 2, you have 100 mLs in, no urine output, but you're still stuck on that 200. Well, here you're only going to be net negative 100. So on hour 3, the nurse is going to come in and make this negative 300. So you're always kind of playing catch up to get to that goal net negative thing. But so this takes a good astute ICU nurse to see what's coming in. What do you got to deal with? And if there's like a big bolus of like a liter in an hour, obviously you can't take that off the next hour. You got to extend it over 6 hours. So this is how, in general, the whole ultrafiltration is done on CRT. Now, sled scuff, like I said, it uses the traditional machine. We already talked about hemodialysis and ultrafiltration. So let's talk about this hemofiltration. This is the last form of dialysis we do with machines that's not PD, and it's slightly different. And so hemofiltration is done more at DH these days than UH. We still do it at UH sometimes. So step number 1 is we're going to do UF again, right? So we got my blood coming in, my blood coming out. There is no dialysate here. And I am let's say I'm getting 3 liters off. Now again, when you do UF, you're not removing a lot of stuff in bulk aside from salt, and the potassium and all that stuff's not coming out that quick. But if you think about it, you can get that other stuff off if you just do UF in a massive way and add a replacement. So all I'm going to do here is just do massive UF, but after I've done UF, I'm going to add 3 liters of something that looks like a dialysate, only because we're in this HF mode, we're going to call it therapy fluid, or we're going to call it replacement fluid, but it's generally pretty much identical to dialysate. So you're in bulk by convection moving sodium, potassium, phosphorus, all this stuff. But if you do this per hour, you really start to move those small and big molecules and move them in bulk. And you get really efficient removal because you're removing stuff and then you're diluting it after the filter. Now, I'm showing this after the filter, which makes sense. In reality, we actually do a pre-dilution, and that's actually a lot less efficient. But the reason we do that is we need to keep these filters open. They clot and they're expensive. So we sacrifice some efficiency for doing that. So we add 3 liters here and 3 liters out. And so if you, and this takes care of your quote unquote clearance, right? This is going to get my potassium out, my phosphorus, my creatinine, my BUN, all that crap out over a long period of time. But you could see it's 3 liters in, 3 liters out. How do you then get the volume off? Well, that part is really simple. All you have to do is put less back in, right? So if you take 3 liters out and then you put 2.8 liters back in, you're negative 200 mLs. And that's basically this hemofiltration in a nutshell. It's just using, instead of diffusion, it's using convection, but in a massive way with replacement fluid. And then suddenly you've got a way to get not only volume off by setting your replacement fluid lower, but now you can get you can get control of your remix solutes when you do it over a very long period of time. And CVVHD is the same thing we talked about. It's just a different machine. So CVVHD, same thing. Blood in, blood out, dialysate in, dialysate out. It's just a different machine run by an ICU nurse. The final form, and it's not really a form, this just refers to nomenclature, is this PIRRT, prolonged intermittent renal replacement therapy. You'll see this pretty exclusively at university. And this is basically like sled scuff with the ICU machine. And so if you think about your semi-stable ICU patient, you're trying to get them out of the ICU. So what you're going to do is you're going to do CVVHD or something, or HF. Let's just do it at night. And then let's let the daytime be for working with PT and getting happy and ambulatory and out of the hospital. So that's the only difference, just doing CVVH on an abbreviated schedule. I know that's kind of a whirlwind through CVVH. Let me just see if you guys have any chat questions. Feel free to anybody to chime in on any of this. Okay. All right, we got, all right. I don't know if I should do some cases or not. Any questions? Anybody want to chime in?
I have a quick question. I got a bit lost on what was run with each machine. It sounds like the UCH and the DH ICU nurse, they do the CRT and the CVVH. And then the hemofiltration, is that what the HD nurse does with sled and scuff? Or where does the hemofiltration fit in?
So yeah, so the ICU nurse and the ICU machine, which is at UH and DH, this is your CRRT. So this is your CVVHD. This refers to continuous veno-venous hemodialysis and hemofiltration, that modality we just talked about. This is a bit of an unfortunate way. All of this is veno-venous, like even traditional dialysis. So it's just really just continuous HD and continuous HF. That's all run by the ICU nurse. And when they do it on a 24-hour, it's continuous. When they do it abbreviated, it's prolonged. And I bring this up just because you're going to see this in notes and not understand it. But the HD nurse only uses the big machine. So that does traditional intermittent hemodialysis. And then if you do that on a slow schedule, that's our sled and scuff. To make it confusing, the CRRT, the ICU machines have a scuff mode. So technically you can do slow continuous ultrafiltration. So you can just do UF on the small machines. But when we traditionally talk about sled scuff, we're referring to the quote unquote big machines run by the ICU nurse. Does that make sense? Or sorry, run by the dialysis nurse. And that's what we have available at the VA. And so we kind of tend to run not 24/7 support in general because you don't need it. This is very, very efficient on a minute-to-minute basis. So you generally only need, 8 to 12 hours of this a day. There will be times we run 24/7 sled scuff here at the VA, and that's like super duper sick people early on, and we've got to have the nurses come in. They don't sit by the bedside for that 24 hours. They kind of come in, turn on the machine, turn it off, troubleshoot it when the ICU nurse says the alarms are going off. But that's kind of, and I'm trying to do the best I can to break down the different modes because they do differ from institution to institution. So at the VA, we just got these big machines. There's no quote unquote CRRT, just sled scuff. And then at the other hospitals, they tend to use the ICU machines more. That's more your CRRT, as it's classically described, CVVH, CVVHD. And then it has a scuff mode, so you can just do ultrafiltration. Did that answer your question, I hope?
I think so. The sled and the scuff, when you run that, do you do like 6 hours of just sled and then a separate 6 hours of scuff? Or
yeah, it depends on how. Yeah, that's great. It depends on how unstable the patient is. I mean, if they're really unstable, we like to separate them. And so when we're doing sled, well, let's just say do 6 hours of just HD. And then with scuff, we'll just do like 6 hours of just UF. But a lot of times we take a little bit off here. So on the sled mode, you can take a little bit of volume. Remember, the filters are the same. So you can do HD and UF with the same filter. It's just when we do kind of sled scuff, when we split them up is usually the sicker the patient, because if you think about what drops your blood pressure on dialysis, well, getting rid of too much volume is big. That's the number one reason, right? But even with dialysis and diffusion, we're dropping osms in the blood, like urea and all these things are building up. And you and me, if we drop our osmolality a little bit, it's not going to affect our blood pressure. But in these sick patients, it will. So when we combine them together, it's more hemodynamic stress. So then when we separate them, it kind of gives us a little less hemodynamic instability.
Gotcha. And then is CVVHD synonymous with the hemofiltration?
No, so CVVHD is dialysis, just like regular dialysis. You got dialysate in, dialysate out, blood in, blood out. Stuff is moving by diffusion. And HF, remember, is just ultrafiltration.
Is the therapy fluid.
Yeah, so it's just UF, but then you're adding back your therapy fluid. So it's a form of dilution, right? We're just massively removing stuff, and then we're putting back what we want the plasma to look like. Yeah, I know it's confusing, guys. I was trying to demystify it a little bit for you. I hope that was helpful. I don't think I have much time. I have some cases to troubleshoot, but again, just trying to work with this whiteboard thing. I hope that was helpful.
Yeah, Dr. Montford, that was fantastic.
Okay. Yeah, please give me feedback. I want to know too detailed, not detailed enough, too fast, not fast enough. Please let me know. First time I did this talk on a whiteboard.